He then spent some time in industry and then finally landed at the Cleveland Clinic and was working for Dr. Hans Lüders and Dr. Rick Burgess. Rick is here today at the clinic. And I think John spent, what, about 12 years?
11 years. Mm-hmm.
11 or 12 years at the clinic. And then he decided that he wanted to pursue a Ph.D. degree, so he came to Case. I was fortunate enough to have the opportunity to work with John for about 4 years. He worked with myself and Dr. Mark Schurer, in particular in looking at developing algorithms for the analysis of sleep EEG for neonates that were in the premature period and trying to connect features extracted from sleep EEG signals with disc maturity and neural development. John then spent some time at the Case Comprehensive Cancer Center after he graduated, doing some informatics work actually for the Case Comprehensive Cancer Center. And when Dr. Lüders came over from the clinic to Case about a year or so ago, and University Hospitals at that time was forming the Neurological Institute, John took a position as a research scientist in the Neurological Institute, working directly with Hans Lüders. And so today, John's going to talk about some technologies, in particular with respect to epileptogenic sources. John?
Yes, thank you. Today we're going to talk about technologies for identifying epileptogenic sources. And first of all, what is epilepsy? Epilepsy is any various neurological disorders characterized by repeated seizures. And repeated seizures are abnormal electrical discharges of brain cells that result in transient disturbances in brain function. And there are various methods for treating epilepsy. The most common is through the pharmacologics, through medicines, but those only go so far, and there are some patients for which they do not have adequate control of their epileptic seizures through medications. Another method of treating epilepsy is through surgery, because if we can identify a particular local region of the brain that is diseased that's causing these epileptic seizures, and if we can determine that that particular part of the brain can be surgically removed without causing neurological deficits, then we have a fairly good prognosis of being able to treat the epilepsy without causing additional neurological deficits. And that's particularly what we're going to be talking about today, is the technologies that are used for diagnosing, evaluating, determining whether or not a patient is a good candidate for the surgical treatment, and how we then plan for the surgery so that we can demarcate specifically the diseased regions that we want to remove and resect, and the functioning regions that we need to preserve. And also, there are other technologies that they're developing for the treatment of epilepsy. One of them is electrical stimulation devices, something called a vagal nerve stimulator, and also deep brain stimulators. These are some emerging technologies. They've had some limited success with that so far, but they are continuing to make improvements and progress on that. And that's also an interesting area for engineering research as well. But today's talk is going to focus mostly on the surgical treatments. Now, the diagnostic tools that we use for epilepsy, although this is just actually a partial list, there are other diagnostic tests that are done, but we do various structural imaging of the brain. For that, we use computed axial tomography, magnetic resonance imaging, and then also, in addition to that, we have various modalities that do functional imaging of the brain that you know, if you see these images of the brain where the structure of the left and the right side look the same, the left and the right side might not be functioning the same. And so there are various tests that are done to elucidate specifically with these differences in function. These are the electroencephalogram, a new technology called the magnetoencephalogram, which we'll talk about later. SPECT is a technology for what's called single photon emission computed tomography, and another related technology called positron emission tomography, and a variation of the MRI called functional MRI, which is a particular design of the experiment that allows for the evaluation of actual brain function. This is an example of the computed axial tomography. This uses X-ray, and the X-ray circles around the head and produces a sequence of back projections, which then a computer is then used to reconstruct the solids. In this particular case, you might see these white dots in there. This particular patient has some surgically implanted electrodes that are used for more accurate localization of the diseased regions. We'll be talking about that as well later on. And then also a very important technology is the magnetic resonance imaging. Now, the magnetic resonance imaging uses a combination of very powerful, very strong static magnetic fields combined with radio waves. And the basic idea is that certain tissues of the brain are paramagnetic. They become slightly magnetized in the presence of magnetic fields. And this is because certain nuclei have magnetic moment that precess in the presence of a magnetic field, and they precess at a certain frequency, and it is possible to measure the amount of magnetization, what's called bulk magnetization of the tissue, by applying an RF signal whose frequency is matched to the precessional spin frequency of the nuclei that is under study. Most commonly, the study involves hydrogen. It has the right spin properties, and it also has the right chemical properties. And basically, what it's showing is that where there's increased signal, there is increased density of that particular nucleus under study. And the magnetic resonance imaging technology differs from CT in the types of the ways that it produces the imaging. CT is very good for hard structures like bone. MRI is very good for imaging of various soft structures. Again, the difference in the grayscales that you see can represent difference in densities of hydrogen, which is why the white matter tends to be slightly a different density than the gray matter, because the density of hydrogen is different in the white matter than it is in the gray matter of the brain. The physics of MRI was worked out in what's called the phenomenological Bloch equations. It's a system of 3 coupled vector differential equations. And this is in what's called the spinning frame of reference. This parameter right here that you see called the gamma is called the gyromagnetic ratio. As we mentioned, the nuclei precess at a certain frequency, and their frequency of spin is proportional to the strength of the magnetic field under which they are being studied, and that constant proportionality is the gyromagnetic ratio. So the basic idea behind that is that once we have the tissue in the strong magnetic field, we then pulse it at a resonant frequency in such a way that we rotate bulk magnetization into the transverse plane, at which time the tissue then re-radiates the RF signal, and that re-radiated RF signal we can then capture with the receiving coil, and it contains information that is useful for reconstructing this profile of the density of the nucleus under study. This is an example, although it's an artificial example, of the re-radiated RF signal after it has been pulsed. The re-radiated signal is called a free induction decay, and it is an RF signal that has a decay rate related to this constant up here, T2, actually T2 star, which is one of those constants that we saw in the phenomenological Bloch equation. And basically, the amplitude of the signal at the beginning is proportional to the density of the nucleus under study. So that's how we can determine the grayscale from the MRI, is by measuring the amplitude of that, usually at the very beginning, unless it's what's called a T2 weighted experiment, in which case we do a little bit of a delay, wait for the signal to decay a little bit before making a measurement. But basically it is based on the amplitude of the signal. So the way that we then get an image, the magnetic resonance image, is that if we pulse the entire tissue and it's re-radiating that signal, we're getting the re-radiation from the tissue, from the entire tissue. Now, if while it's re-radiating, we apply a magnetic field gradient, which is a magnetic field that is strong at one end and weak at the other, then again, because of this gyromagnetic ratio, it will cause those portions of the tissue that are in the strong magnetic field to shift towards a higher frequency, and those portions of the tissue that are in the weaker field to shift to a lower frequency. And then by applying a standard Fourier transform, we can then find that the distribution of energy of the free induction decay is analogous to the distribution of the density under study. This is a one-dimensional case, and then to generalize this to higher dimensions, 3 dimensions, is that we use a combination of gradients. First we do a slice selection, and then we use other gradients that can resolve it in the x and y direction as well.
Can I ask, what is FID?
I'm sorry?
FID?
Oh, free induction decay. That was the, this is the free induction decay. And so basically, you know, in reality, what we would have is that if we have a large tissue which has a distribution of protons distributed throughout a space in some way, and it's all re-radiating, and then we apply a gradient on it, if we, you know, the amount of density of that which is in the strong field is going to produce high frequencies, and you know the tissue that's over in the weaker areas is going to produce lower frequencies, and that's all going to be combined in one free induction decay, and then we can separate all of that out then from the Fourier transform. And again, the way that we do the imaging is that we use multi-dimension Fourier transforms. So in addition to that, the magnetic resonance imaging is a technique that provides structural imaging, but we would also like to be able to do functional imaging. And that's done through indirect measurements of the function of the brain, being that different parts of the brain, when they perform different tasks, have a higher metabolic demand. And the body then, in response to that, will provide a greater concentration of blood flow to meet that demand. So what these scientists who were developing the MRI realized is that blood is a paramagnetic material. That is to say that blood becomes magnetized in the presence of a magnetic field. And so because of that, that shortens what's called the T2 relaxation time. If we go back to that free induction decay, the decay rate becomes shorter if we put some kind of a paramagnetic material in that particular area. So wherever there's large concentrations of blood, this free induction decay will decay faster. And so then what they're able to do then is by first doing an imaging of a baseline and then doing different experiments where the brain has to go through different kinds of mental tasks, we can then see changes in local T2 relaxation time, and then do that from a subtraction with the baseline image, and then that produces a profile that looks like this. This is actually a superpositioning of a structural image MRI plus this functional imaging in the false color that you see right here. But basically, what this will show is that this particular part of the brain right here is metabolizing at a higher level than other parts of the brain. Now, the reason why this is important is because the parts of the brain that are related to the focus of epileptic seizures tend to under-metabolize between seizures. They metabolize at a very high rate during seizures, but in between seizures, they tend to metabolize at a lower rate. So then by comparing, for example, the left side of the brain with homologous regions on the right side, we can see if they're balanced, if they're not. If we see that there's certain areas that are under-metabolizing, then those become indicators of possible sources of the epileptogenic focus. Another technique that's used is called single photon emission computed tomography. And this technology involves injecting a patient with a radioactive tracer. Usually for this particular type of brain studies, they use an isotope called technetium-99. And it is, it tends to concentrate again with blood flow. So where there are large regions of blood flow, then there are large regions of this particular radioactive tracer. And then we take this, the person, we put them inside of a ring of detectors, and then it's able to then show a concentration of where the blood flow is based on the rates at which it's detecting these events. Another technology that's very similar to that is called positron emission tomography. And basically the difference between positron emission tomography and SPECT, single photon emission computed tomography, both of them involve the injection of a radioactive tracer. But PET scans use specifically radioactive isotopes that decay with the emission of what are called positrons, antimatter electrons, and when they encounter an electron, they annihilate each other, giving off a pair of gamma photons that go in opposite directions. So then by placing the patient inside of a ring of detectors here, you'll see that what they do in this design is you're looking for what's called coincidence detections. If we find a detection at one end of the ring, we don't count it unless we find a detection at the opposite end of the ring, because we know that that's an indication of positron decay. And that distinguishes this event from background radioactive activity, and so therefore we're able to improve on our signal-to-noise ratio while at the same time keeping the concentrations of our dangerous radioactive tracers at a lower level. So in other words, what we get is we get an improved image over the SPECT, the single photon emission computed tomography, without having to increase any risk to the patient. Well, of course, also one of the most important techniques that we use in the diagnosis and diagnosis of epilepsy is the electroencephalogram. This is an example of an electroencephalogram, and basically, the way this works is that every trace that you see here is taken from a pair of electrodes that are placed over the surface of the head, and they're put into a differential amplifier. And so basically every trace that you see is not really telling us the activity at a single point, it's telling us the activity at 2 points, and in fact the difference of those. But nonetheless, by knowing where, oh, by the way, a pair of electrodes is called a derivations, and a set of derivations is called a montage. So over here we see this is the montage for this particular case. And by studying this, if you look carefully, you know, maybe you've never seen an electroencephalogram, this right here is the onset of a seizure. If you see how there's this abrupt change in the activity going from this activity here into this very large amplitude, slow activity right here. That's where a seizure is starting. But this is also indicating that the seizure is starting at one particular part of the brain. They don't always start that way. Sometimes the entire brain activates into a seizure pattern all at once. And those types of seizures are not surgically treatable because there's no focus that we can surgically remove. But if the seizure onset is identified to be a single focus, and that focus is a part of the brain that we can safely remove, which actually is often the case, not always, but often it is the case, then we have a very good prognosis of curing their epilepsy. And also, for patients who have epilepsy, in between their seizures, they often produce these abnormal events right here called spikes, interictal spikes. And these are very brief, transient things that don't show any clinical symptoms. If a person has one of these brief spikes, you wouldn't know it other than if you saw it on an electroencephalogram. But nonetheless, these spikes are very important for both the diagnosis and the treatment of the epilepsy. We use this also because these spikes give us a lot of very useful information in identifying the focus or the source of the epilepsy. And then also, in some cases, not in every case, it is necessary to use surgically implanted electrodes that are placed right over the surface of the brain. These are very closely spaced electrodes here that you can see. These are about 1 by 1 centimeter apart. And this is if the focus is very close to or overlapping functioning regions of the brain. And so this allows us to get very accurate demarcations of the epileptogenic regions. But it also allows us to then, we can apply small electrical currents through these electrodes here so that we can do functional studies. If we, for example, put current through one particular electrode and the patient then suddenly loses the ability to speak, for example, then we know that that particular electrode is identifying a speech region of the brain, and we need to spare that. We can't take that out. So that allows us then for very accurate demarcation of the functioning regions and the disease regions of the brain. As I showed before, when we showed both the CT, the computed axial tomography, and the MRI, we use the CT for imaging the patient after we've inserted these electrodes. It's not safe to do the magnetic resonance imaging with the electrodes in place because these electrodes can induce current and they heat up, and that can cause some damage to the brain. So therefore, it's necessary for us to do two separate images. One is the magnetic resonance imaging, and from that we can use a combination of all the image slices to do a surface rendering of the cortex of the brain, and then combine that with the CT images, which also have the placement of the electrodes, so that we can then identify specifically where each electrode is with respect to the corresponding part of the brain where it's placed. Okay, well now we're going to talk about EEG source localization. If we see one of these interictal spikes that we've identified, we'd like to know where in the brain that came from. And this is an example of a spike. And again, what we would do is we'd look at this montage over here, and this particular one, based on the placement of those electrodes, are telling us that that particular spike, which you see right here, is occurring somewhere over the right temporal region based on the placement of those electrodes and based on the distribution of the spike right here. But we would like to have an accurate understanding of specifically where that came from. And in order to do that, we go back to the physics of what's generating these spikes. And for that, we can look at an individual brain cell called a neuron. And each brain cell processes various ions that are processed inside of the brain. And the actual orientation of these ions then will cause the neuron to form a dipole. So each neuron in the brain becomes a small dipole. And then when each of the neurons, which are formed in the brain in a parallel structure along the surface of the brain, they form networks of these dipoles so that their strengths will sum up. Each individual neuron is too weak for us to be able to see from the surface, but when we have millions of these neurons combined together, we can each small dipole combined in large numbers will produce a potential that is large enough for us to be able to detect from the surface. Now, one of the problems with using the electroencephalogram in localizing the source of these interictal spikes is that, as you saw, these neurons form along the surface perpendicular to the cortical surface right here. So if, for example, a spike happens right here, then its projections would be right underneath where we would see the maximum field distributions on the electroencephalogram. The problem is just that sometimes the source might be in some part of the brain where it's the cortical surface is at an angle. It's projecting obliquely. And so in cases like this, we would see a maximum field distribution somewhere over here, but the actual source is somewhere over here. So we call that false localization, and it's a difficult problem. And in this particular case, I'm demonstrating that we have the two different separate hemispheres of the brain. And in this particular case, you can see that the methods of using an electroencephalogram would localize the source of the spike to the wrong hemisphere. So that's that's a real problem. Now, in order to try to get a more accurate localization of these sources, one technique is to use what's called source dipole localization. And for that, we use the we know if we have a dipole somewhere in the brain, and we know its position, we know its strength, we would be able to compute the electric field potential produced by that dipole based on the physics of what we know about dipoles and how they work. So that's the forward solution. If I have a dipole, I know what the surface distribution would be. The inverse solution is the problem that we're working with, which is that we have all the surface potentials, but from that we want to be able to work back to the location of a dipole that produced that. This is, of course, assuming that what we're observing from these spikes is actually produced by a dipole, and under certain circumstances that assumption is considered to be reasonably good. But it's not necessarily always true, but if we can verify that that is the correct model, then we can do parameter estimation on that model and get a fairly good estimation of the location of the dipole. So basically, in order to do a source dipole localization, we just use the standard model for the dipole, and then just take a least mean squares estimation of the dipole, and then that will give us the coordinates and the orientation as well as the field strength of the dipole. And so that allows us then to do a source localization from a set of surface potential distributions. So here's an example. There's a spike right here. It's kind of difficult to see, but there is a spike somewhere right up around in here. And again, from this distribution, that's coming from the right temporal area. Again, over here on the right side. And then when we do a source dipole localization, now basically what this is showing is the distribution of all the electrodes in 3 dimensions. And then this red device right here is the computed estimation of the source localization of the dipole that's producing those surface distributions that we saw on the previous page. You can also rotate this around. This is a projection of all these electrodes that you can see it's actually a 3D thing. And there are other ways that you can represent this. You can superimpose that dipole from the magnetic resonance imaging images as well. Special issues in computing the source dipole. One of them is the Montage Selection. Again, the source of the set of derivations that we use. Tissue conductivities, the number of dipoles, temporal measurements, and sources other than dipoles. The Montage Selection, the method of least squares estimates the source localization with respect to all surface electrodes. Therefore, the reference must not be involved. The 2 options are non-cephalic reference and a common average montage. Now, basically what this means is that, again, because we're using combinations of electrodes and putting those in pairs into differential amplifiers, we need to find some electrode that's not involved. It's something that's electrically silent. And so the 2 options for that is either by using an electrode that is not on the head, but those tend to be very problematic. They're prone to different other types of artifact and noise that can occur, such as EKG or movement artifacts or whatever. And then the other is to take all of the electrodes and then to compute an average of all of those and then use that as a reference. This is something that's specifically done on computers, but that usually gives the best results. Non-uniform conductivity of different tissues is really one of the biggest problems. And that has to do with the fact that when we do the forward solution of our dipoles, if we're trying to compute what would the surface potentials be, those forward surface potentials are greatly dependent on the different intermediate tissues that the fields are passing through. And the brain has one conductivity, the bone has a different conductivity, the skin has a different conductivity, and because the bone has different thicknesses in different regions, it can have lower conductivities along certain pathways than in other pathways, and so therefore we might get surface measurements that are a little bit skewed because of that, and that can greatly affect our estimation of the location of these dipoles. So one way to try to compensate for that is the fact that we do have the MRI information. And so this is an example where if you see there's a little red dipole that it's placing right there. It's not, I don't know if it's coming through all that well, but this is doing a source localization. But basically, when it's computing the forward solutions, when it's trying to do this least squares estimation, it can use the MRI information to figure out what the actual conductivities are from a particular location to a particular surface value by looking at all the intermediate densities from the MRI. And then from that, we can use estimated values for conductivities. We have estimations for conductivities for gray matter and white matter. And we also have different estimation for conductivities of the bone. And so this allows us then to compensate and control to some extent for intermediate conductivities. If, on the other hand, if this patient has recently had surgery so that there's a skull breach, there might be some part of the bone that was cut, then the signals in that particular part of the brain are going to be very high because the conductivity pathways are going to be very high. And those are sometimes very difficult to control for, even with the MRI. But in those cases, we usually don't do source dipole localization. Then also, sometimes a single dipole is not the appropriate model. It might be that what we're observing on the surface is a combination of multiple dipoles. So in that, we just simply modify our model so that the source comes from a summation of multiple dipoles, and then again we do our least squares estimation from that, considering each of the dipoles to be independent. And from that, we're able to estimate the location of multiple dipoles. Now, this is an example. If we see this particular dipole right, oops. If we see this particular dipole right here, this is the spike that we're looking at right here, and this indicates that it's coming from on the right temporal. But the dipole over here seems to indicate that it's coming somewhere in the center of the brain, which doesn't make sense. And then if we repeat this using two dipoles, we find that it's coming from the right temporal region, which is where we would expect that it should be coming based on our reading of the electroencephalogram over here. And in this particular case, we see that the two dipoles tend to orient themselves in opposite directions. And so a single dipole will try to model that the best as it can, but it can't because it's not the appropriate model. So one of the most important things in doing this is that we have to make sure that we're matching the appropriate model for a particular observation.
John?
Yes?
Can you go back to that slide? So in that example, those two dipoles have the same effect of the single dipole that you showed before this?
Well, you see, what it's doing is that with a single dipole, it's trying to do a least squares estimation of a field, and it, I might have to skip ahead. Here we go. Basically, we can show the field distribution of the electric field distribution over the surface of the head. And we have these two colors. You see how it's using the red and the blue for positive and negative values. And sometimes what you'll see, a typical dipole will look something like this, where we'll see all of these concentric circles in red, and then all these concentric circles over here in blue. One of them is representing the positive end of the dipole, and the other is representing the negative end of the dipole. But sometimes you'll have distributions, like if you see down here, this one, where we have blue in the middle, and then red on the left and the right. And so if you try to model that with a single dipole, it'll do the best it can. You'll always get an answer with a least squares estimation. It'll say a single dipole best fits this distribution here,
But the location won't necessarily be like geometrically between the two dipoles?
It's wherever the single dipole best fits that the distribution that you see. And it all depends on what that surface distribution is. And so in this particular case, it should be because of, the particular symmetry that we have. But sometimes you don't have that perfect symmetry. Sometimes you'll see that we have a large red over here, and then a blue, and then a small red over here. And so a single dipole is, where would you best fit that? It might be somewhere a little bit to the left, but it's going to place it the best it can. But the main point is just that it's an inappropriate model for the process that we're observing. And so when we do that, then our parameter estimation isn't going to be all that meaningful. But the whole point is just that, once you do get an appropriate match, then it should, then it should give a reasonable result.
So how do you tell when it's an inappropriate model and you need to go to 2 or 3 or 4?
Well, okay, let's just back up. Okay, so how to select the number of dipoles? Yeah, basically there are some rules of thumb here. One of them is that we don't want to exceed the number of degrees of freedom of the system. And remember, each of these dipoles has 6 parameters. And so if we have 2 dipoles, we have 12. If we have 3 dipoles, we have 18 parameters that we're estimating. And if we have only, for example, 16 electrodes that we're recording from, then at some point we're going to have more parameters than degrees of freedom of the system. So we don't want to do that. We have to limit the total number of dipoles. And then second of all, we're observing the changes in the residuals for the increase of the number of dipoles. Basically, that's the chi-squared, the total sum squared value. We're looking to see how that's changing. And then there are also these information theoretic techniques. There's something called the Ake-Eke information criteria, which means that we can calculate an entropy for each dipole model that we use. We use a single dipole, calculate this value, then we calculate 2 dipoles and 3 dipoles. And then an Ake-Eke information is something that should bottom out when the model matches the process. Now, I've also worked with this before in autoregression modeling and had limited success. I mean, it's something that's not perfect. That's the way that it's supposed to work. But, finally, you just ask the question, does it make sense? And, one of the guidelines that I use in trying to make sure that I'm matching the appropriate model for the observed process is by looking at those field distribution maps. If we do a 2-dipole model, we look at the forward solution from the 2-dipole model, and then we compare that with the observed field distributions. And usually, if it's a reasonably good fit, then you say, okay, well, it looks like that's probably the appropriate one. And then if we go to a 3-dipole and it doesn't really improve that field distribution maps all that much, then we've probably gone too far. We always want to try and go with the minimum number of dipoles. Usually we can do it with just 1 or 2. Occasionally we need to go to 3, but the main thing is just that there are these checks that we use when we're sequencing through the different model orders to make sure that we're matching the appropriate model for the observed process. And again, in some cases, well, in fact, this is the next example that we're going to talk about is the fact that dipoles are not always the appropriate model to work with. This is an example. If we look at the distribution of a spike like this, we see that its distribution comes from pretty much all over the brain. And in this particular case, a dipole is probably not actually the source that we're observing. It's something that is involving a large amount of cortex in both hemispheres, and trying to model that with a dipole would not be appropriate. It's always these very localized events that tend to make the most sense when we use dipole localization. Well, also, we have these cases where the dipoles change over time. We tend to sample, we frequently sample the electroencephalogram at 200 hertz. And so each sample point is about 5 milliseconds apart from the next one. And we can compute source dipole localization on a sequence of these sample points and then look to see how that progresses over time. And sometimes we see that the sequence tends to move in a linear direction because it's propagating over the surface of the cortex. And in some cases, they tend to rotate because the cortex of the surface isn't flat, and it goes up and around and then comes back. And sometimes you'll see that happening where the sequence of dipoles will appear to be rotating. This is an example of a moving dipole where we have a sequence of points. And this is about 5 or 6 computed dipoles, and you see that they propagate linearly along a particular direction. And again, the rotating dipole is because of the fact that the surface of the cortex is not flat. It tends to, it has these mountains and valleys, and as the dipole is propagating over the surface of that, its orientation is changing, and so even though its position isn't changing that much, its orientation can make it appear as though it's rotating. Well, there are other sources and models that we can work with. One of them is neural networks, finite element methods, and parameter estimation. Well, of course, source dipole localization is parameter estimation, but working with other models, models that have other parameters associated with them. In the method of neural networks, basically what we can do is, if we're able to actually physically insert a dipole into an artificial test experiment, or perhaps even in some cases into a cadaver, if you wanted to try to make it realistic, and then make measurements on the surface, and then use that as the compilation of a training set, we can use neural networks for source localization. And the objective behind this is just that this takes a lot of the guesswork out of what all of the intermediate conductivities are and all the other kinds of things for which the source dipole localization is sensitive to. The finite element method, it would be nice if we could actually do this using finite element solution of Poisson's equation. And this is derived from the current density equations. And basically, ultimately, we're going to start with current densities, and somewhere down here, we're going to end up with Poisson's equation, where we're going to relate the potential, the surface potential values, to the charge density function. And it would be nice if we could do that. Unfortunately, normally when we solve these equations, we know what the forcing function is, and we know what the boundary conditions are in the formulation of the Dirichlet boundary conditions of elliptical partial differential equations. But in this particular case, we don't know what the forcing function is. That's what we want to try to resolve. And because we don't have a detailed understanding or detailed measurements of all the intermediate values, the problem becomes ill-defined. And so we're not able to solve for the Poisson's equation. That's why we're forced to work with certain assumptions that constrain our calculations to different models. So Poisson's equation is ill-defined. For this reason, the method of choice involves parameter estimation of a model source. Source localization of seizure onsets can be computed in the time domain or the frequency domain, or use bandpass filters for time domain analysis. Now basically, as we were mentioning, a lot of our analysis so far has been on the analysis of these interictal spikes, but localizing the onset of seizures is also very important. And this is an example right here, again, of the onset of a seizure, epileptic seizure. And we can do source localization of selected points on those, but sometimes those are very highly unstable. They tend to go all over the place. But basically, the method or the strategy in working with the seizure onsets is just that we just have to work with aggregates. We either calculate a sequence of these points, we look to see if they cluster, and then we try to find the centroid of that, or we do a frequency domain transform of that, and then we can do source localization of a selected frequency band in the frequency domain. But basically, the Fourier transform is just another way of aggregating the data, because it's going to involve an integration of the signal over time. So you're doing it either way will give you basically the same results. In this particular case, this is an unaggregated result. I know that it looks like kind of a mess, but if you look down here, it does actually cluster to a particular region of the brain, and the centroid of all of that does tend to give us somewhat of an indication as to the onset of the seizure for this particular case. Another technology that's used is the magnetoencephalography. And this is based on the concept that the currents in the brain produce small magnetic fields. And we can measure these magnetic fields and then use that for source localization. The special detectors that we use from those are called SQUIDs, superconducting quantum interference devices. They're highly sensitive to even small changes in magnetic fields. So these magnetoencephalograms have to operate within highly shielded laboratories to block out all the background activity. Otherwise, it picks up all the background activity and gets swamped by that. But basically, we would be working with two of the Maxwell's equations, the Faraday's equation and Ampere's equation, for both the production of the magnetic field and then how the magnetic field is then inducing currents in our squid detectors. And there are certain differences between the MEG and the EEG. One of them is the fact that the electric and magnetic fields are orthogonal, and so it gives us complementary information. Information that we get from the MEG is going to be slightly different than the EEG. And also, but one of the main advantages of the MEG is the fact that it is not so sensitive to the tissue types. And so with the electroencephalogram, although we're very much dependent on what the intermediate conductivity values are from the source to the electrode or the sensor, in the MEG, the magnetic field is passing through all of these tissues is pretty much the same way that they would pass through free space. And so therefore, we don't have to have a detailed knowledge of what these intermediate conductivity values are. MEG measures tangential signals, those in sulci, whereas EEG measures both tangential and radial. This is a bit of a problem for the MEG. Basically what that means is that, as we mentioned, the surface of the cortex is not flat, and so it produces these mountains and valleys. Basically what this means is that the currents produced in the valley portion of the cortex are the ones that are visible from the MEG. The ones that are at the top of the mountain, so to speak, produce magnetic fields that are orthogonal to our detectors in a way that they're not, that we can't measure them, that we can't see them. So only certain locations on the surface of the cortex are visible from the MEG. And another is that the magnetic fields spatially decay quicker and are therefore not as well suitable for deep brain measurements. The MEG is very good for measuring activity nearer to the surface and more difficult to measure deep brain activity, more difficult than with respect to the EEG. But another advantage is the fact that the MEG is reference-free. We're not taking pairs of electrodes into differential amplifiers, so therefore we've resolved that whole problem of what reference do we use. And of course, another big issue that makes it different from the EEG is the cost. The MEG is a much more expensive tool. As of right now, it's still being evaluated, but more and more it's finding its way into common clinical use. Now, I did a little bit of a literature search on a couple of articles as to the accuracy or comparing the accuracy of source localization from MEG and EEG. And MEG does better than the EEG, and over the years you can see that both of them are improving, where the MEG stays in front of the EEG. But, it's getting to the point where both of them are considered to be pretty good, within a centimeter for the EEG and less than half a centimeter for the MEG. Now, another method that we use in the analysis of these signals is something called principal and independent component analysis. And this is a technique that allows us to extract events of interest from other unrelated or background activity that is sometimes problematic when we try to do our surface field measurements. If we want to know how a particular spike distributes over the surface of the head and it happens to come at the same time as some other event is happening, then we would like to be able to separate these signals out so that we can study the spike independent of the other one. And we use a technique for that called principal component analysis, or blind source separation. And in a very simple way, if we have multiple sources and multiple receivers, we can understand that the receivers would be just simple linear combinations of these sources. And the principal component analysis algorithm here is outlined in this slide right here, where basically what we're doing is we're computing a covariance matrix where it's the means are subtracted out. And then we diagonalize the covariance matrix, and then from that we can construct a transformation matrix, which then allows us to reconstruct signals of independent sources, independent of other activity that's going on. So just by way of an example, if we were to have two signals, if this is one source and that's another source, but the way that we receive them at our receivers is through linear combinations of those two sources. After the application of the principal components analysis, we would see one source separated out, and we would be able to get good amplitude measurements of each independent source at each of the receivers. And then again, the other activity would then be separated out, you know, through this method called principal component analysis. And that's very good because that way we can take the spike, we can do a principal component analysis to extract it out from the background activity, so we get a good clean measurement of that. This is an actual example of principal component analysis. There's these two lines right here, and there's this activity here that you might see to the left, and then another activity over here to the right, and they show up here as this and this. These two components of the principal component analysis are separating out those events quite well. And here's a second example. In some cases, you have these activities, you know, just even eye blinks can cause deflections. And if we get a spike during an eye blink, then this is a very good way of separating out those events as well. So, you know, again, what we want to do is we first do a principal component analysis followed by source dipole localization. That gives us a much cleaner signal to work with, so we can get a more accurate estimation of the source localization. And a related technique is called independent component analysis. And basically, it has the same objectives as principal component analysis, except that rather than trying to express these signals as linear combinations of uncorrelated basis functions, we want to express them as linear combinations of independent bases, which is a stricter requirement than uncorrelation. Signals can be, if they are independent, they are uncorrelated, but if they are uncorrelated, they are not necessarily independent. So this is a technique that is stricter, and it tends to give better results. If you have a tool that does both principal and independent component analysis, I just always use independent component analysis. I can't think of any reason why principal component analysis would be preferred if you had both. There's also a technique called event-related potentials, and this is a technique where, you know, we'll use some kind of a sensory stimuli, such as a flash of light or sound or tactile stimulation, and each of those then produce some kind of response in the appropriate part of the brain, depending on whether it's vision or hearing. And that allows us to then localize different functioning parts of the brain. First of all, we measure the response, and then we can do a principal component analysis of that to separate out the different response components from the conduction pathways based on how the signal is propagating through the brain and being processed, and then do source dipole localization on each of those. That allows us to do a localization of independent functioning regions of the brain, which is different than what we've been doing all along, where we're trying to identify the sources of diseased regions of the brain. So this is basically an outline of that whole technique. Then we would take the ERP, then we would do a principal component or independent component analysis followed by a source dipole localization of that, and that allows us to get a localization of functioning regions of the brain. And that's very useful for planning surgery. Localization of pathogenic and functional areas may not be adequate in delicate areas of resection, but even if it's not, at least it can help to improve the planning of the placement of these invasive electrodes. If you remember those electrodes, that picture of those electrodes we were placing right on the surface of the brain, sometimes we don't even know exactly where to place those electrodes. And what we might find out is that you place the electrodes, and then when you go to make your measurements, you find out that the functioning region that you really wanted was only partially covered, you know, that the grid that you placed might not be quite placed exactly right. And so some of these techniques, even if they're not good enough to plan for the surgery as far as the actual cut, it still might be good enough to help plan for the other tests that allow us to do the resection that we need. Okay. Well, future research, you know, these are all works in progress, and we're continuing to improve on the automated detection and recognition of epileptic events. That's something that Dr. Farhad Kafashi will talk about sometime in the future, different methods that we're using to develop for those. Improved methods of epileptogenic localization and improved methods of functional localization. And also, once we do all of this planning for the surgery, there are also other engineering technologies that are involved in implementing the surgery. So there are different computer systems that are commercially available for assisting neurosurgery, and so the results of what we're doing here is something that we then pass on to some of these other technologies so that they can actually then do the surgery. But then these are all areas of active research that are going on right now. So thank you very much.